Welcome, everybody. Hello, everyone. I'm Sarah Jewell, the Assistant Director of Clinical Services and Manager of the Myra Mahan Patient Resource Center. I'm thrilled to welcome you all to our first in-person seminar in a long time, and my first ever seminar as manager of the MMPRC. The Myra Mahan Patient Resource Center aims to make accurate, science-based health information easily available so that patients and their families can make informed decisions about their care. Through its collection of online databases, pamphlets, and staff, the center aims to live up to its namesake. Myra Mahan lived from 1937 to 2011, a licensed clinical social worker who believed that an informed patient is almost always a healthier patient, with a better chance for a favorable outcome. PRC works collaboratively with world-class physicians and healthcare providers at Weill Cornell Medicine, who are committed to delivering outstanding primary and specialty care to all patients. I'd now like to introduce our speaker today for our seminar on idiopathic neuropathy. Norman Latov, MD, PhD, is Professor of Neurology at Weill Cornell Medicine, specializing in peripheral neuropathy. He attended Columbia College, graduated from the University of Pennsylvania School of Medicine, served as medical intern at Boston City Hospital, and completed his neurological residency at the Neurological Institute of Columbia Presbyterian Medical Center, where he was also chief resident and postdoctoral fellow in immunology. He served as Professor of Neurology and Director of the Peripheral Neuropathy Clinical and Research Centers at Columbia University and Weill Cornell Medical Center, and his laboratory is credited with the discovery of anti-MAG and GM1 ganglioside antibodies, which are routinely tested for in clinical practice. He authored over 200 publications, including research papers, review articles, and book chapters, and lectures widely on subjects related to neuropathy. Dr. Latov is also founding board member and medical and research director of the Neuropathy Association that subsequently merged with the Foundation for Peripheral Neuropathy and has been selected as one of America's or New York metro area's top doctors by Castle Connolly annually since 1998. He is the author of Explaining Neuropathy, Symptoms, Diagnosis, and Treatment, or When the Pain Won't Stop, written for people with neuropathy and their families and friends. Please welcome Dr. Latov.
Thank you for that flattering introduction. Usually introduces an expert, which is just one rank below influencer. And it's not that difficult to be an expert on a subject there isn't much known about. There isn't much to read. There's very little written about idiopathic neuropathy, but it's something that we deal with in the office all the time, and it needs to be addressed. So first, what's the definition of idiopathic neuropathy? Well, medically speaking, we use a term to describe any condition where the cause is unknown. But it's not an exact translation. Idiopathic actually translates to a disease of its own, but obviously many people have it, so it's not unique. A more appropriate term would be cryptogenic, which means hidden, of unknown origin, either because it wasn't tested for or because we just don't know enough to recognize it. But we use it as a fancy way of saying I don't know, because we don't know what it causes, which is frustrating to many people, especially patients. One of whom said, it's a blend word combining idiotic and pathetic. So here we are. Now, this is a cartoon illustrating what happens in a doctor's office when the doctor is trying to explain idiopathic neuropathy to a patient. Both the doctor and the patient are perplexed. They are confused. They don't know what it is or what to do. But that's a starting point. Now, Going back, just to put in perspective, we have to discuss how neuropathy is classified. So we usually call it according to its distribution, nerve fiber type, course of the disease, and cause. If it's a known cause, we mention the cause. If it's an unknown cause, we call it idiopathic. The distribution could be purely motor, purely sensory, purely autonomic, proximal, distal, multifocal, involving the plexus, or combination. You know, some jaw-breaking words such as radiculoplexural neuropathy. Try to say that 10 times. The nerve fiber types could be large or small, or axonal or demyelinating. The course could be progressive, could be remitting, relapsing, or stable. So you can see, putting all these together, you get a plethora of types and names of neuropathies, which can be very confusing. This is just to illustrate a cross-section of the spinal cord with the nerves coming out. So I don't have a pointer, but anteriorly the motor nerves come out from the front of the spinal cord. The sensory nerves go into the back of the spinal cord. Proximal to the spinal cord, they both separate from each other, they don't go together. They then travel together in the nerve trunk, distally to the arms and legs, and then separate to motor nerves, which go to muscle, or sensory nerves go to skin and internal organs, etc. And depending where the lesion is, you could end up with a pure motor neuropathy, pure sensory neuropathy, or a combination of the two. And this just illustrates a nerve fiber. You can see the big dark circle in the middle. There's a large axon with a normal myelin sheath, in dark black. And the nerve fibers could include these large myelinated axons, smaller myelinated axons, or unmyelinated axons. Each of these has different functions. So the large fibers are always covered with myelin, which is a sort of insulation membrane that allows them to transmit the signal faster. And the neuropathy could be primarily demyelinating, affecting the myelin sheath, or primarily axonal, which is like the wire, like the copper in a wire. Whichever is involved primarily, the other one is also secondarily involved to some extent because they're interdependent. Small fibers, usually refer to them as axonal, although some could be demyelinating. The motor fibers move the muscles. These are large myelinated fibers. The large myelinated sensory fibers provide information about the position of the joints in space. If they're damaged, they cause imbalance. And small fibers convey, small axons convey pain sensations and autonomic functions, and they're damaged when patients develop strange pains and dizziness and standing up, either from too rapid a heart pulse, called postural tachycardia, or low blood pressure, which is called postural hypertension. They could have temperature intolerance or gastroparesis as manifestations of neuropathy. Various studies to tease out the type of the neuropathy and the extent of damage and location of damage. So if you have neuropathy, you probably get EMG nerve conduction studies, which are electrodiagnostic studies. The nerves are just like wires. They transmit electric impulses. And I don't know if you remember from high school physics, you stimulate a circuit, you look at the oscilloscope, and you can see how the signal moves, how fast it is, and the height of the amplitude. We do the same thing with nerves. It tells us how well the nerves function. The EMG is mostly useful for evaluating motor nerves because we have the muscle end organ that receive these signals. It's not that good for sensory fibers, so to evaluate sensory fibers, we use spinal somatosensory rote responses, which is again stimulating the end organ and following the signal as it's transmitted up the nerves to the spinal cord and up to the brain. And then if the damage is mild, or only the small fibers are affected, the EMG studies would be normal, and in which case we could do a skin biopsy or epidermal nerve fiber biopsy, which allows us to enumerate the nerve endings in the skin, and in small fiber neuropathies or mild neuropathies, these could show neuropathy when the EMG studies are normal. And then we could have various ways of looking at autonomic functions. We use something called tilt table test to evaluate for changes in blood pressure and pulse from lying to standing to see if there's a response. Look at variability of heart rate. Usually the heart rate decreases when you expire and increases when you inspire, and if you don't see the variability, it's an indication of some dysfunction of the autonomic nerves. So these are all tools to evaluate nerve functions. Now, it's very important to be able to distinguish between demyelinating and axonal neuropathy. Again, demyelination primarily affects the insulin sheath. Axon is sort of like the copper part of the wire. The reason is there's a limited number of causes of demyelinating neuropathies, and except for the hereditary type, they're all treatable. So if you have a demyelinating neuropathy, we test for various causes. If the tests show a cause, we treat it. If it doesn't show a cause, actually, we diagnose the neuropathy as CIDP, or chronic inflammatory demyelinating neuropathy, which is defined just by the pattern of abnormalities in EMG showing demyelination, with all the other tests being normal. And that condition is treatable with immune therapies. So most demyelinating neuropathies are treatable. Axonal is more complicated. There are many more causes for axonal neuropathies, and sometimes we don't know the cause. So if the tests don't show a cause, we can treat the underlying cause. We don't know what it is. So depending on whether EMG shows demyelination or axonal degeneration, if all the other tests are normal, if you have demyelination, it's treatable. If there's no demyelination, then it's not treatable, which obviously is an important distinction. So it's very important that the EMG nerve conduction studies be done properly and comprehensively to make sure that demyelination is missed. If it's done, without care, then the treatable diagnosis may be missed, which is why we spend an awful lot of time on these procedures at our center. Axonal neuropathies, whether they're large fiber or small fiber, all have the same causes. So again, when you look for the causes, depending, it's irrelevant whether your neuropathy is large fiber or small fiber. Again, this is just a diagram going through the differential process. Patient presents with suspected neuropathy. They undergo EDX, electrodiagnostic studies. If it's demyelinating, if these show demyelination on the right, we do blood tests for known causes. If one of these is positive, we treat that cause. If it's negative, we'd still diagnose it as autoimmune and treat with immune therapies, and patients usually get better. If it's axonal, we check for known causes. If we find a cause, we treat. If we don't find a cause, we call it idiopathic. There are no idiopathic demyelinating neuropathies. All the idiopathic neuropathies are axonal, and there's no treatment except for supportive care, physical therapy, pain medications, etc. And small fiber neuropathies that are diagnosed by skin biopsy, I treat the same as axonal. There are form of axonal neuropathies that only affect the small fibers, or they're very mild, so they're not picked up by the EMG. So, moving along. Now, this is just a listing of demyelinating neuropathies without going into great detail. There's something called acute inflammatory demyelinating neuropathy, which is Guillain-Barré syndrome, which most people have heard of. Chronic inflammatory demyelinating neuropathy, CIDP, which is treatable with immune therapies. Something called multifocal motor neuropathy, which is demyelinating, which is treatable. Anti-MAG neuropathy, MAG is monoassociated glycoprotein, which causes demyelination, which is treatable. And there's something called POEM syndrome, which is demyelinating neuropathy associated with myeloma, also treatable. Some demyelinating neuropathies are hereditary. We know the cause. There are a number of companies working on treatments, but nothing available yet. And some drugs can induce demyelinating neuropathy, such as amiodarone, especially in higher doses or in people with renal disease. As I said, there are many more causes of axonal neuropathies. There are endocrine and metabolic, such as diabetes, thyroid disease, renal failure, many infectious causes, Lyme, hepatitis C, HIV, more recently COVID. It could be autoimmune. There's an axonal form of Guillain-Barré syndrome, something called Sjogren's syndrome, which is associated with dry eyes and mouth. Vasculitis, which is inflammation of the blood vessels. Celiac disease, sarcoid, which is inflammatory changes in nerve, and lupus, among others. Some neuropathy is secondary to cancers, most often lymphoma or lung cancer or myeloma. There are nutritional causes. Alcohol toxicity is the best known. In the old days, there were only two known causes for neuropathy. One was alcohol toxicity, the other one was diabetes. So if you didn't have diabetes, people thought of you as being an alcoholic, and if you denied it, that proved it. So people didn't talk about it much. But now we know there are many more causes for which we look for. Certain toxins can also cause neuropathy. Here we see a lot of mercury toxicity from seafood. Certain types of seafood have high mercury levels. People think seafood is healthy and they eat a lot of it. Sometimes they develop neuropathy symptoms, and if they're tested, the mercury level could be high. The half-life of mercury in the body is about 3 months, so if they are high, we tell people to stay off seafood for 2-3 months. Then they can reintroduce it, but probably no more than twice a week if they're prone to developing high mercury levels. And the same people also take lots of vitamins, one of which is B6, and too much B6 can also cause nerve toxicity. So both these occur mostly in wealthy people. Seafood is expensive, vitamin pills are expensive. So it's a disease of affluence. And there are certain hereditary neuropathies which are axonal. We know most of the causes of hereditary demyelinating neuropathy, but only about half the causes of hereditary axonal neuropathy. So that's still being investigated. So the cause is important. This is just to show that different treatments work for different types of neuropathy in different people. So depending on the diagnostic test, we did decide a treatment. Not the same thing works for everybody. What else can it be if all the tests are negative and yet you're diagnosed with idiopathic neuropathy? Or sometimes people have nerve damage that's left over from a prior damage, and the tests don't show the prior damage. You'd have had to be tested at the time the damage occurs for it to be diagnosed. That can happen with Guillain-Barré syndrome. People get acutely ill, then you recover, but you can have residual weakness or sensory or pain, or sensory dysfunction or pain. After chronic inflammatory demyelinating neuropathy, even if they're treated, they can have leftover symptoms. Lyme disease can do that. I know there's, for example, lots of argument about whether there's such a thing as chronic Lyme. In most cases, and some people think it's autoimmune or that the infection is still present. In Connecticut, doctors are allowed to prescribe antibiotics for years for presumed ongoing infection. That's because the governor's wife had chronic Lyme. But in most cases, it really turns out to be leftover damage. The Lyme disease caused some damage. Lyme was treated. It's no longer active, but people are left with symptoms. They don't get worse, though. Leftover symptoms don't cause worsening. They just cause ongoing symptoms, which often fluctuate. If it's progressive, though, it's important to distinguish whether the idiopathic neuropathy is stable or fluctuating or progressive. It's progressive that something else is going on. It's not leftover damage. The diagnosis could be missed if not tested for, so it's important to have comprehensive testing. Sometimes you have to repeat some of the tests because early on the cause may not be obvious, and repeating some of these tests may show the cause. And in some cases, only a nerve biopsy may show the cause. So if the disease is progressive and no cause can be found, we should recommend doing a nerve biopsy, which could reveal certain treatable conditions which are otherwise missed. We don't like to do it unless it's clear that neuropathy is progressive, but it's an invasive test and can cause lingering pain sometimes, so we don't recommend it lightly. Now, it's important for people to be able to tell whether the neuropathy is getting worse or not. Often people come in and they say, oh, I think it's getting worse, I feel more pain. We evaluate them and do the exam, repeat the electrical study, and actually, it seems that the nerves are doing better, and we explain to the patient, and they would say, oh yeah, I thought maybe it might be getting better, but I was worried, and it came in. So it's important to be able to evaluate whether the neuropathy is getting worse at home. So as I said, fluctuating symptoms usually mean that the neuropathy is the same, and sometimes you feel it, sometimes you don't. Symptoms could be triggered or affected by various environmental conditions. For example, low barometric pressure can cause increased tissue pressure, more pressure on the nerves and more symptoms. That's why people with arthritis sometimes feel pain when there's a storm coming, with barometric pressure. Hormones could affect how sensitive the nerves are, food, etc. And sometimes you could detect patterns, sometimes it's not obvious. And motor functions are more reliable than sensory functions. Motor functions are things like walking and evaluation of strength or fatigability. Sensory symptoms are not reliable because you can have more pain either because the neuropathy is getting worse and you have more damage, or because it's getting better, the nerves are more sensitive. So you really can't tell by sensory symptoms just whether the neuropathy is getting worse or not. You have to rely on the exam and the electrical studies, which actually measure how well the nerves are transmitting signals. So any suspected progression should be confirmed by more objective tests. Now you could do that at home. You could test for grip strength. You can get a dynamometer. I'll show a picture in a minute on Amazon for $7. Measures how strong your grip strength is. You squeeze as hard as you can with each hand. You repeat 4 times, take an average, and log it. And you can have good and bad days, but usually the result is within a range, and then you can see if the range is improving or getting worse or staying the same. With leg strength, so that's for the hands. For the legs, you can evaluate strength, and you have to find a function that you could do with a little bit of difficulty. So you can see whether it's getting easier or more difficult. If you can do it easier and you can still do it easily, it doesn't mean it hasn't gotten worse. It hasn't gotten bad enough so you can't do it. So for example, the sorts of demanding functions that you could test for is getting up or walking on your toes or heels, getting up from a chair, getting up from the floor with either leg, going up or down stairs, or running, Anything that you could do with some difficulty would be a sensitive measure of change that you could follow at home. Walking speed is also useful. Walking is a composite of strength, balance, how wide you keep your feet, how high you pick up your legs, how long they're off the ground, etc. So typically you can measure up 25 feet somewhere, walk it as fast as you can, time yourself, repeat several times, average, people out, and you see if there's a change. If you're having physical therapy or go to the gym or play golf, you could use these to see how your motor function is doing, whether there's a change. So this is just shows the handheld dynamometer. There are different types. The one where there's a ball which measures hand grip and as opposed to finger grip is probably more reliable. This is just illustrate using golf skills if you play golf to follow neuropathy function. What if the symptoms in the examination shows worsening? Repeat some of the tests. Again, the electrical studies may not show much early on. It'll be obvious, but if you repeat them, they show a definitive pattern, which could be CIDP, which is a treatable disease. And blood tests also could be borderline early on, but if the neuropathy progresses, they may become more obvious. If you haven't been tested for hereditary neuropathy, you can get that done and have DNA tests. And hereditary neuropathy can occur, including in family that don't have a history of neuropathy, or we usually think of it as occurring in young people, but sometimes it could show itself in elderly individuals. So differences in penetrance of the abnormal genes. And there are all kinds of stories, people come in and say there's nobody in the family, and it turns out, at least in the old days, people didn't want to talk about hereditary conditions because it might make their kids less, sort of desirable or marriageable. But now actually those things, if you know you have a hereditary neuropathy and a defective gene, you could actually test using vitro fertilization to get rid of it. So it's important that people know that they have a defective gene, and then there are various choices as to how to manage that. And there are now several drug companies that have medications for some of the hereditary neuropathies, which are very effective. So you don't want to miss that diagnosis. Also, as I mentioned earlier, sometimes a nerve or muscle biopsy would show a cause that's not obvious on blood tests. So if the neuropathy is progressive, we recommend doing that. It has to be done in specialized centers, though, where there's an experienced surgeon could remove a piece of nerve without leaving scars, and a pathology lab that's able to evaluate the specimens properly. So this is an example of electron micrographs of section of a nerve biopsy. You could see the normal myelin axons, or dark circles, thick circles, and the arrow showed to a couple of axons which should have thick myelin sheath or black circles, but don't. And this is indication of demyelination, and the patient has CIDP in the biopsy. This just, the fibers could be teased, and again you can see the myelin in black, and there are regions where there's no myelin sheath, the axons are naked, again, characteristic of the disease. This just shows nerve what we call vasculitis, which is inflammation of the blood vessels in the center of the photograph. Again, it's a treatable condition. Sometimes it can occur in other parts of the body, which could be biopsied, but sometimes it only affects the nerve and muscle, so we need to have a nerve and muscle biopsy to make a diagnosis. It's called non-systemic vasculitis as opposed to systemic vasculitis. which affects other organs, which might be easier to biopsy. There's something called amyloid, which is the position of immunoglobulin fragments in the nerve. It shows as this waxy material. Again, usually affects other organs too, but sometimes just the nerves and muscles. And there's something called sarcoid, which is sort of a collection of inflammatory cells. Again, most frequently occurring in the lung, but sometimes in other organs, and sometimes only in the nerves and muscles. So these things could be identified in nerve biopsies. Now, what if the neuropathy is progressive and all the tests, including nerve biopsy, are negative? In the old days, people used to give steroids because it might be autoimmune or inflammatory, and some people did better, and other people developed diabetes. More recently, people started using IVIG instead because it had anti-inflammatory actions and not as significant side effects as steroids. But even IVIG can cause thrombosis, deep vein thrombosis, and sometimes stroke. So over time, people have become more averse to taking risks for various obvious reasons. So nowadays, we rarely treat the neuropathy with immunotherapies unless we know what the diagnosis is. But still, if it's rapidly progressive, there's nothing else available, we consider it depending on the risk tolerance of both the physician and the patient, and whether many of these are expensive therapies and whether the payers have agreed to reimburse for it. What about alternative treatments? Well, they're called alternative because they're not proven to be effective. Most are naturally occurring, not patentable, so clinical trials are expensive, hundreds of millions of dollars, so there's no way to sponsor the trial to find out if they are effective or not. And these types of treatments are usually not regulated and sometimes could be harmful. For example, you could still go online and see recommendations, advertisements for high B6 for neuropathy, even though we know that B6 can be toxic to nerves. So it's kind of the Wild West out there with respect to alternative treatments. What else could be done? Certainly we can offer supportive therapies, physical therapy to help strength, orthotics to help ambulation. We could treat the neuropathic pain, and we could treat the autonomic symptoms. But if you want to be involved in helping the cause and do something about it, if you're very wealthy, you can help support research directly. Otherwise, you could join with other people with neuropathy organization to advocate for NIH funding for research in neuropathies. NIH is responsive to Congress, and most congressmen would love to meet with you if you get 10 or 20 people together, and if you have something that they can help with, it, they actually might be persuaded to make recommendations in Congress regarding research, which is very important. That's it. Questions?